Is it visible now?
Yes, sir.
Yes, sir.
So this is the case scenario we are given. 28-year-old male patient diagnosed to have acromegaly, posted for TRANSPHENOIDAL resection of pituitary adenoma. So first question is, how are pituitary tumors classified? Something about basic pathology and
Macroadenomas and microadenomas.
it is based on the size. You can say macro and micro. Any other classification?
Functional and non-functional.
Functional or non-functional. Very good. So pituitary adenomas can be classified based on their size and hormone secretion. If it is less than 1 centimeter, it is called microadenoma. If the size is more than 1 centimeter, it is called macroadenoma. Similarly, it can be a functioning adenoma where secretion of specific hormones causing symptoms are visible clinically, and it can be non-functioning, like a silent growth usually present as macroadenoma, and this will produce more of a raised intracranial pressure symptoms like a headache and other things, but hormonal effects will not be seen. Okay? And apart from these two direct growths in the pituitary, there can be other tumors present in the cellular region, that is the sella turcica or the pituitary fossa region. You can have other tumors like craniopharyngiomas, meningiomas, or malignant growths can also happen, but they will all be totally devoid of any hormonal effects on the body. Now, what is the clinical presentation of this condition? Already she has said, but the classical features are, it can be neurological symptoms due to mass effect like headache, nausea, vomiting, visual changes, hydrocephalus, growth retardation, etc. Or it can produce a condition called Parkinson syndrome, decreased pupillary light reflex, paralysis of upward gaze, and retraction convergence nystagmus. These three are present. It is called Parkinson syndrome. And it can be sometimes an incidental finding when you do an imaging for something else where the gland growth is very silent, and they are mostly large glands causing macroadenomas. And third thing, they can produce or manifest as hormonal abnormality, over or under production of hormones. So the clinical symptoms can be any of these three types. It can produce neurological classical symptoms. It may be a silent growth with suddenly incidentally found out when you do some investigation for some other reason, or it can clinically present with all the abnormalities of the hormone production. So the types, depending upon the increase in the number of cells, it can be lactotrophs producing prolactin, or it can be a non-functioning null cell, or corticotroph producing corticosteroids, somatotrophs producing growth hormone, gonadotrophs producing luteinizing and follicular hormone, thyrotrophs producing thyroid gland abnormalities, and craniopharyngiomas, which are non-hormonal growth structures which there. So what investigations are needed for this? That can be again classified into estimation of all the hormones which we suspect that may be produced in excess, like prolactin, insulin like growth factor, plasma ACTH, cortisol, and total and free thyroxine, thyroid stimulating hormone, all the anterior pituitary hormones we can test for the level to find out whether it is a functioning adenoma or a non-functioning adenoma. Along with that, we must do the basic metabolic profile of electrolyte and metabolic abnormalities, and as a routine, we must do the complete blood count also. Pharmacological treatment for this particular condition, acromegaly, Dr. Jemima correctly mentioned, it can be as analog, like it can be a somatostatin analog like octreotide, and or it can be other drugs, dopamine agonists like cabergoline, bromocriptine for certain types of adenoma, or we can block the effects of growth hormone also by the drugs that are available. The operative treatment to remove a functioning adenoma is either transsphenoidal or transcranial surgery, which is the most recommended treatment for pituitary masses. And of that, TRANSPHENOIDAL is the most soft factor because this is supposed to be technically more easier than transcranial. Because for transcranial, what sort of approach you will have to do? Can you do just a burr hole and remove a part of the bone like you do for other craniotomies? Or is it a more difficult and very elaborate resection?
You have to go via the occipital.
The guessing is logical, but it is not the way. We'll have to do a bifrontal craniotomy. Okay, we have to remove the mid portion of the anterior aspect of the scalp and then do a big craniotomy, which is called the bifrontal craniotomy. So this is a more tedious and a long procedure. So most of the time, adenomas are removed by TRANSPHENOIDAL. So there are complications because of that also. But comparatively, this is much more easier, and duration of surgery also will be less, and in good hands it produces very good results without any complications. Now coming to the anesthetic considerations, preoperative evaluation and management. First thing, evaluate the pituitary function by doing all the hormone assays. Okay? And acromegaly and Cushing sometimes may coexist also. Here patient may have increased risk of hypertension, diabetes, cardiovascular disease, electrolyte abnormalities, etc. So routine echo, HbA1c should be done. And airway problems, especially in acromegaly patients, are due to anatomic distortion as well as comorbidities, where they may have OSA also, and they may be huge and have obesity problem. And if they have a horse or strider, it may indicate a retrolaryngeal nerve or laryngeal stenosis produced by this particular condition. And a malambity grade 1 or 2 may be falsely reassuring in these patients. And once you put a scope, you may find you are not able to see the larynx at all. So this is a notorious case for difficult intubation. Even sometimes bag and mask ventilation may also be quite difficult in these cases. And the excess growth hormone can lead to thickening of pharyngeal and laryngeal soft tissues, macroglossia, just like your Peary-Robin syndrome, reduction in the size of the rhima glottis, and hypertrophy of arytenoid folds and soft palate and epiglottis. All these things will make the normal size tube intubation quite difficult. That is the reason why I told you you have to have smaller size tubes ready. And they may have enlarged thyroid, which may cause tracheal compression, lower drone also. That's another reason why a normal size tube cannot be passed through this patient's trachea. And symptoms of raised intracranial pressure can occur due to large tumors and should be identified prior to surgery. This is another important point in the preoperative evaluation, which we have to keep in mind. And a pituitary MRI scan will help to assess the position and extent of the tumor that is needed, so that we can plan to manage intracranial pressure depending upon the size and location of the tumor. And coming to the monitoring and initial challenges, what are all the monitoring you need? Apart from the regular conventional ASA guided monitoring like pulse oximeter, EKG, NIBP, ETCO2, temperature. No, these 5 things are standard monitoring. Any other extra monitoring you need? And is there any challenge in that in acromegaly patient?
Sir, intra-arterial BP monitoring is required, sir, and the challenges are due to carpal tunnel syndrome. It is difficult to get the radial artery.
Fantastic, very good. So that is an important thing. So where will you place the cannula if you can't put it in the radial artery?
Dorsalis pedis, sir.
Dorsalis pedis, sir.
Alternate, yeah, that's a very important point. So acromegaly patient may have ulnar artery obstruction due to carpal tunnel syndrome. So always do a Allen's test. How do you do the Allen's test? How to perform Allen's test? Allen's test, modified Allen's test. There are so many things. If the ASCII question is on arterial cannulation and intra-invasive BP monitoring, this question will automatically be asked. What is the purpose of doing this Allen's test?
To make sure both the radial and ulnar arteries are patent.
Collateral circulation is present. That is the correct terminology you must say. Collaterals. Okay. So you occlude both the radial artery and ulnar artery at the wrist and ask the patient to clench the fist times, and you see the palm. It will become pale because there is no blood supply. Now what you do, which one will you release first, radial or ulnar?
Radial.
Radial is the major supply, ulnar is the collateral. Okay,
Ulnar.
so you must release the ulnar pressure and see whether the palm becomes pink immediately. That means the ulnar artery is patent and collateral supply is good. Then you release the radial artery. Then you reverse that and make sure that radial artery is also patent. Okay, radial artery is the dominant supply for most of us in the normal anatomy. Sometimes, rarely, ulnar may be there, and even if radial artery is occluded, ulnar will always try to supply by collateral. So first you release the ulnar artery, look at the palm. If it becomes pink, that means collateral supply is good. You can go ahead and cannulate the radial artery. And even if something happens, ulnar will take care of that and will not go into gangrene. Okay, so this is the other point that you have to keep in mind. And precordial Doppler, because there is a small risk of venous air embolism, because this surgery, transsphenoidal adenoidectomy, pituitary adenoma excision, is done by head-up position. So there is a possibility of venous air embolism, and you should have large bore peripheral IV access. It's because there is a condition called kissing carotids. What is kissing carotids anomaly? Have you heard of the term?
No,
Okay,
sir.
I'll tell you later. I'm going to show you pictures also. Depending upon the need for abdominal fat or facial free flap, what is the need for taking this abdominal fat graft or free flap? Which may be a part of the surgical procedure done to remove the pituitary adenoma itself. Sometimes, you can have a CSF leak, which a surgeon will identify while doing the surgery itself. The transsphenoidal, it is a microscopic surgery. So when they try to remove the enlarged adenoma, there may be a small rent in the dural covering, meningeal covering, and CSF may start leaking through the nose. So in order to close that, they may use a abdominal fat graft or a facial free flap. So if they plan to do it in the primary sitting itself, they may keep the thigh and abdomen ready. So the draping and painting and draping will be done in these areas also. And you always use a oral cuffed flexometallic endotracheal tubes and fix it on the opposite side of the surgery. This is a very important thing because normally they go through the right nostril to do the transsphenoidal adenoidectomy. So the tube has to be pushed to the left corner of the mouth and fix it on the left cheek so that it doesn't get dislodged or it doesn't come in the way for the surgeon while he is operating. And a throat pack is inserted by the anesthetist, and it must be pulled. The tail of that pack should be kept along with the plaster adhesive that you keep for the endotracheal tube, so that you can remember and remove it at the end of the surgery. And you must always have backup airway equipment like VDA laryngoscope and small size endotracheal tubes. And all connections in the breathing circuit should be checked and prior to the start of the surgery, because once they drape the patient, getting an access to the mouth and the head will be very difficult. So make sure that the circuit connectors to the endotracheal tube and the other HME filter or whatever you are using, all are securely connected before you allow the surgeon to paint and drape. And protection of pressure points is important, as surgery may be quite lengthy. Especially you must protect the eyes by proper covering and padding. And unexpected hemodynamic changes can happen because when they do the transsphenoidal approach, they usually use a vasoconstrictor. Like, what is the common vasoconstrictor we use when we want to do a nasal endoscopy or nasal fiber optic intubation or any nasal surgery? What is the common vasoconstrictor we use?
Adrenaline.
Oxymetazoline.
Oxymetazoline. What is oxymetazoline?
Alpha 1 agonist.
Alpha 1 agonist. Fantastic. So that is causing a selective vasoconstriction effect. So oxymetazoline will be used, and in addition to that, surgeon may also infiltrate the area with adrenaline containing xylocaine. Okay, these two things can cause a rise in BP, and that has to be kept in mind, so that rise in BP can raise the intracranial pressure if the patient already has a raised ICP. Okay? And intermittent pneumatic compression device or TED stockings is very, very important, because there is a possibility of venous pooling in the lower limb, and which can result in DVT or pulmonary embolism. Okay? So this picture gives you the exact position, okay, of how the head is supported in the frame. This is called Mayer's frame, which will be fixed. And this is the nose, and this is the operating axis for the surgeon, and this is the position adapt with a leg in this. So you can see how the venous pooling can happen in this position. So TED stockings and pneumatic compression devices are used, and the surgeon and his assistant will be standing here. Anesthetist will have to stand here, and patient's head will be turned towards the surgeon slightly. So you cannot have any reach for the endotracheal tube or the connection. So you have to make sure that everything is kept ready. And this is the view that you get through the scope. So it may be by the monitor, you can see all these things when they introduce the scope here. So we talked about lumbar drain for controlling the ICP in these patients. How is it done? Any idea? Idea?
They're
Okay,
using
right.
system catch cannula at L3, L4 space.
You must answer. You want me to wait so long for the answer to be?
Sir, I forgot it, sir.
Pituitary tumors with significant supracellular extension, they may, the ones which I told you as the beginning itself, which will cause the rise in intracranial pressure. If it is confined within the cella turcica, it will not cause that much of problem. So there you may need a what is called some lumbar subarachnoid drain to be sited. To achieve this, you can use a standard 16 gauge epidural catheter, which is inserted at L3, L4, and you have to thread the catheter 10 centimeter into the subarachnoid space where CSF is present. Okay, and you can inject the 10 ml of normal saline under strict aseptic precaution. This will help to push the tumor out so that the surgeon can easily remove the tumor. So that is the one reason for keeping the lumbar drain. The other reason is if there is a CSF leak, by keeping this lumbar drain and removing part of the CSF, the flow from the cranial CSF compartment will gradually come down, and within 24 to 48 hours, without any further necessity for closing that leak, the CSF leak may stop. So there are two reasons why the lumbar drain will be kept in some cases. One is to help the surgeon remove the tumor by pushing the tumor out of the cella. The second is by reduce the intracranial CSF pressure so that CSF leak also reduces. And urine output and fluid balance monitoring is also very important whenever there is a hormone secreting tumors are there. And large tumors, they cause the risk of diabetes insipidus also. What is the meaning of the word diabetes insipidus? Normally, we talk only about diabetes mellitus. What exactly is, which language is the origin of these words, diabetes mellitus and diabetes insipidus? Most of the medical terminologies are all drawn from which language?
Latin, sir.
Greek and Latin. Okay,
Right.
these are the two languages. And in diabetes insipidus and diabetes mellitus, is it only Greek and only Latin, or Greek and Latin both?
Both, sir.
Both. Diabetes is Greek and the insipidus or mellitus is Latin. What is the meaning of these two words? One is Greek word and another is a Latin word. What is the meaning of diabetes? What is the meaning of mellitus? What is the meaning of insipidus?
Sir, one is sweet smelling urine. Which
Sweet
is what?
smelling, not tasting, not
Sweet-
smelling. Sweet does
Sweet
not
tasting.
smell.
Sweet tasting.
Mellitus means honey-like. Okay,
Honey.
it is like honey-like mellitus. Insipid means tasteless. Okay, so in diabetes insipidus, it is a urine which is tasteless. Probably those days they found out by licking it. Okay, because there were no other methods to find out. So whereas diabetes, the word is a siphon or drain. Okay, that is the meaning. So diabetes mellitus means draining or siphoning of sweet urine, whereas in diabetes insipidus, draining of tasteless or insipid urine. Okay. And what are the types of diabetes insipidus? This is one of the short note questions in the theory exam also. For those who are likely to take up theory exam, you must know something about diabetes insipidus. There are two
Central and
types.
nephrogenic.
It can be cranial and nephrogenic, or neurological and nephrogenic. What is the difference between the two? Cranial or neurological, I told you ADH is very important hormone for maintenance of water balance or fluid balance in our body to maintain the osmolality. Okay, when the ADH is not performing well, it is an anti-diuretic hormone, which means it should not allow diuresis to take place. It should not allow too much of urine to be formed. When the function is blocked, anti-diuretic function is blocked, what will happen to the patient?
He'll end up passing more urine.
He will pass lots and lots and lots of urine. Okay, and that urine is tasteless. That is diabetes insipidus. On the contrary, if the kidney is not responding to the ADH that is produced, then also water retention cannot happen. Which level in the kidney the ADH acts? Which part of the nephron the ADH is acting?
Distal and collecting duct.
Distal collecting tube, distal convoluted tubule and the collecting duct. Okay, that is where it is happening. And you know how the mechanism, it causes water reabsorption?
Through aquaporin channels, sir.
Aquaporin is a protein which will be inserted from the basolateral membrane towards the luminal membrane. So it is just like a temporary conduit. Whenever you need to reabsorb the water, the aquaporins will be inserted into the luminal cells and water will be absorbed, and the aquaporin will again be removed back. Okay, that is how the whole water is being reabsorbed in that. And this action, if it is not happening in the kidney level, that is called diabetic nephrogenic diabetes or diabetes insipidus caused by the kidneys inefficiency. So in the cranial or neurogenic diabetes insipidus, it is a faulty production or release of ADH, whereas in the nephrogenic diabetes insipidus, it is the non-responsiveness of the nephron to action of ADH. Okay, so that is there. But ultimately, the result is same. Lots of volumes of urine will be passed by the patient, which will dehydrate him. So patient's sodium level will go up. He will go in for hypernatremia, and the osmolality will increase. Okay, and so we'll see that little later. Describe the intra-op and post-op management. Balanced anesthetic technique using opioids and neuromuscular blockades are usually done to manage the hemodynamic derangement. And you can use total IV anesthesia also, which will help in a smooth emergence and reducing the post-op nausea and vomiting after this particular surgery of transsphenoidal adenoidectomy is very, very important. Why?
Vomiting can cause raised
Oh.
ICT.
So, even if the surgeon has closed the wound,
CSF rhinorrhea, sir.
CSF leak will happen. Yeah, CSF leak will be there. So, you understand, absolutely no nausea and vomiting during emergency. And transsphenoidal approach requires special consideration during emergence, like avoiding positive pressure ventilation, which will again raise the intrathoracic pressure, which will raise the intracranial pressure, which will increase the CSF pressure, and again CSF leak can happen. And similarly, avoiding coughing on emergence, nausea, vomiting on emergence, and nasal packing will be done. So patient should not struggle to breathe. So these things can be achieved by the wonder drugs that we have now today, namely remifentanil and dexmedetomidine infusions, can help in achieving all these requirements after this particular surgery. And suctioning the stomach and hypopharynx should be performed by the surgical team prior to turning over the airway to the anesthesia team for management. So normally we anesthetists only do the suctioning, but in this case of transsphenoidal, it is better we ask the surgeon to pass a nasogastric tube orally, not nasally, and then try to suction the stomach so that the chances of nausea and vomiting will be less before we plan for extubation. And blind insertion of gastric tube should not be done at all in these cases, because sometimes through the hole they have made to remove the adenoma, the catheter can go into the skull also. That is one of the risks. And patient should be made to breathe spontaneously, and smooth extubation should be done. Sometimes they advocate using Bailey's maneuver to achieve a smooth extubation. What is Bailey's maneuver?
Using an
We
LME.
will use
Supraglottic airway device before removing the endotracheal tube.
Endotracheal tube. Very good. Excellent.
deep sedation. Deep.
So the complications of pituitary surgery are, one is fairly quite severe bleeding can happen because it may be venous or arterial. If it is venous, simple packing will help to stop the bleeding. But if it is arterial, as I told you, the kissing carotids, which I will show you the picture now. If you injure the internal carotid artery, which may sometimes be running close to the sella turcica or the pituitary fossa, then you can have a torrential bleeding. So you must be in that situation. You have to abandon the surgery and then make a craniotomy and go ahead and to complete the procedure. The second important common complication is CSF leak, which patients later on may suffer from headache, rhinorrhea, and salty taste in the mouth due to postnasal dripping. And the persisting CSF leak may be resolved by leaving the lumbar drain for 1 to 2 days, allowing continuous CSF drainage through the lumbar drain. And sometimes it may require a surgery like putting a fat graft or a facial lata flap inside and sealing that. And the third complication is diabetes insipidus, and neurogenic results from destruction of ADH secreting cells in the posterior pituitary or hypothalamus are from impaired release of ADH from these cells. So it is mostly the neurogenic type of diabetes insipidus you will have and not nephrogenic. And the polyuria, where the urine specific gravity will be very low. What is the normal specific gravity? You forget this point, then you will say 1005, isn't it, this number? You can remember 1010 to 1020, okay, or 1010 to 1020. But when you write, you put a full stop, stop mark here. Okay, 1010 to 1020 is the normal specific gravity, but here it becomes very diluted, so the specific gravity becomes to less than 1005, and osmolality decreases more than 300 milliosmoles because of I'm sorry, this is less than 300 milliosmoles, the diagnostic feature of diabetes insipidus. And sometimes you may have SAADH also because of the abnormal release of ADH because of the transmitted damaged posterior pituitary cells. And clinical signs include low serum sodium and plasma. In SAADH, there is a loss of sodium along with water, and plasma may be higher, and the urine osmolality may be greater than plasma osmolality because sodium is also lost in the urine. And lastly, venous air embolism may be also happening in these patients. So these 5 important risks you have to keep in mind. Now I am showing you a picture of the extended tube. Sometimes, patients with acromegaly, you have a very long mandible. Their oral cavity and the reach to the trachea will be quite lengthy. So the normal endotracheal tube, what will be the maximum length of a normal endotracheal tube we use in an adult? Every day you are using a Protex tube or a Mellon Cross tube of endotracheal PVC disposable tube you are using. What is the maximum length you will get in a tube?
29 to 30 centimeters, sir.
32 maximum. Okay. So you will have 20, 22, 24, 26, 28, 30, 32 like that. Okay. Whereas when you are supposed to use a smaller size tube, the length will not be the same. It will stop at 28. Okay. So that may not be sufficient for that. So what they have done is, what is A is a 5.5 size tube which they could intubate with because of the narrowing of the glottis, but the length is not sufficient. It is not reaching up to the incisor level. So what they have done is, they have cut a bigger size tube and attached it to the smaller size tube distal end by removing the connector. Okay. So this picture shows you a 5.5 millimeter inner diameter tube. This is the A. B is the 6.5 tube inserted into the 5.5 millimeter tube after removing the connector to make it longer. So you can choose any length and then insert it so that you will get a longer length. So this is one of the things that has been shown in one of the articles where they managed by lateral thinking to achieve intubation in a patient with acromegaly with a very small opening in the glottis, which will not allow the normal size tube to go. So the smaller size tube, lack of length, made them think of adaptation like this. And in this picture, you can see the 2 internal carotid arteries close by. And that is called the kissing carotids in the contrast CT that you are seeing. So if you see this picture, surgeon has to be very, very careful, and as anesthesiologist, you should order for sufficient blood and keep it ready in case it starts bleeding. Okay. And this is another picture. Can you identify what is A and B? I told you about another complication that can happen in the trachea. So A is the compressed tracheal opening, and B is the large thyroid swelling which has happened in the lower down. Okay, so this is the reason why you may sometimes not be able to intubate with a normal size tube. So this is the compressed tracheal shadow, and this is the retrosternal goiter which is causing the compression. And this is the comparison of a normal person with a acromegaly. The differences are prominent forehead, enlarged nose, enlarged lips and lung, prominent chin and jaw, or elongated chin and jaw. Okay, so this is the comparison between acromegaly cases and the normal cases. Okay. So these are all the things I thought I will share with you. Okay. Any questions on that? Any doubts? Okay. None of you are answering immediately. I don't know why. Okay. Kamachi, are you there?
Yes, sir. The other doctor, Akash, his wife is admitted in ICU, sir. So he'll be not able to present today. Just got the
Okay.
message.
Right,
So
right.
can we discuss some OSPs today, sir?
What is the other topic that we are supposed to discuss?
Parkinsonism case coming for.
I will just show the slides and finish it off. I can't be waiting
Yes, sir.
for all that.
Thank you, sir.
So what are the, I will just ask questions. Let us see whether other people have prepared something or they are all just giving the responsibility to the person presenting. Let us see what is the knowledge of the students on this particular thing. What are the features of Parkinson's disease and why is it called so? It's a free for all. Anybody can answer. Even though the presenter is unfortunately not able to present it. Let me see whether all of you had any interest to learn about this before you come to the class or not.
Rigidity, tremor.
Okay.
Bradykinesia.
Yes, good. Go ahead. You're
Tremor,
right.
T.
Tremor, rigidity, or
Bradykinesia.
bradykinesia, mask-like face. Isn't it? These are all the things. Parkinson's, a disease name given to clinical syndrome comprising of tremors, mask-like faces, bradykinesia, dysarthria, and rigidity. Okay. So 1, 2, 3, 4, 5 features. Tremors may be predominantly tremors with all the other things very mildly present, or it may be predominantly rigidity with other things mildly present, or it may be a combination of both in equal quantity. Okay, so it can be comprising of any of these 5 things: tremors, mask-like faces, bradykinesia, dysarthria, and rigidity. Why it is called so? What is the reason for calling it as Parkinson's disease? Logical, just logical answer. Any disease named by somebody's name, it is to be by the person who discovered or described it, isn't it? So it is called Parkinson's disease after James Parkinson, who first described this condition. Okay, so it is not something new. What are the other names for this condition? Heard of other names at all?
No, sir.
Okay, so this is
Paralysis.
characteristic stoop tall Chaplin's skill is also called the happy disease. Very rarely this is known to people, but other diseases, so all of you would be knowing about Charlie Chaplin, how he walks and all those. So initially they thought it will be the feature like this for a patient. And because Charlie Chaplin was a comedian, they thought it's a happy disease. It's not so. The other names are Parkinson's disease, Parkinson syndrome, Parkinsonism, shaking palsy. This is the name given by James Parkinson. He actually called it as shaking palsy, not Parkinsonism, but later on it was named after him. So what James Parkinson described was shaking palsy because of the tremor. And there is also a name called paralysis agitans, which also means Parkinsonism. Okay. What is the pathophysiology of this condition? What
Sir,
exactly
decreased decreased dopamine transmissions and neurotransmission. And
Availability of dopamine at which level of the brain?
Basal ganglia, sir.
Substantia nigra of basal ganglia. Okay, specifically that particular, why that particular part is important?
Because it
What
has circuits for coordination of movements.
That is motor activity, cognition, and the coordination of motor activity is done in that particular part of the brain. And to do that, you require dopamine as a transmitter. Okay, so when the dopamine is not available, the coordination is lost, so you get either tremor or rigidity, that particular condition. So pathology is the destruction of dopamine containing nerve cells at substantia nigra of basal ganglia. This is the location. And the substantia nigra shows marked depletion of the so-called pigmented cells, which are replaced by glial tissue. This can happen as a degenerative process because of the age, or it can happen due to trauma. People who have undergone open heart surgery in those days, even for CABG, after 15-20 years, the incidence of Parkinsonism is very high in those people because of the lack of blood supply that has happened to this area of substantia nigra during the surgery. Very slowly the cells got destroyed and many of them developed Parkinsonism. So if you ask them whether they underwent any open heart surgery with a cardiopulmonary bypass, majority of them will have a positive answer for that. So what preoperative evaluations to be made? So these questions have to be, first you make a diagnosis and ask for the duration, because this disease is such a wretched disease. Many members in my family suffered, and I had the personal experience of keeping some patients in my house and treating them for until their last days, including my father-in-law. So I knew what are the difficulties in this. As the days go by, the pharmacological treatment response gradually goes down and the rigidity becomes more and more, and does not allow the patient to move on his own. They require a lot of help from others to even go to the restroom and come back, eat. Everything requires help. So the diagnosis, as the duration gets prolonged and the disease becomes worse, and assessment of associated changes in the various systems, which we will see now. The surgical procedure intended, whether you want to do an elective or emergency surgery, and what is the anti-Parkinson's drug the patient taking and their potential interactions with our anesthetic agent, and preoperative continuation of the main drug levodopa, which is given as the primary treatment for these conditions, and pre-medication. What sort of pre-medication? We cannot use the regular pre-medication that we use for other cases. And these patients, when the disease becomes more and more severe, they are not able to, even the pharyngeal muscles become weak and swallowing becomes a big hurdle or hazard. So they aspirate very frequently. So aspiration prophylaxis also to be decided whether when they have a difficulty in swallowing also. The common problems and what surgeries are needed in these patients. The common problems, mostly it happens beyond the age of 60 or 65, and they present with geriatric problems because of the aging. And the common surgeries they come for are, they can come for a prostate surgery or incidental general surgery like hernia or piles, and cataract surgery and gynecological surgeries in the female are the common surgeries for which patients with Parkinson's may come to us. And the effect on the other systems. Any idea what are all the systems that will be affected in Parkinson's other than the neurological problem?
Sir,
Fantastic. First and foremost is autonomic dysfunction present can produce diverse manifestations as orthostatic hypotension, siluria, constipation, incontinence, and frequency, excess sweating, and seborrhea. All these things. Very good. Then, which other system can be affected?
Sir, usually hypertension, so cardiovascular system.
Cardiovascular system. Okay, very good. So, respiratory function also can be affected because of the rigidity and muscle weakness. Pharyngeal muscle weakness leads to increased retention and impaired expulsion of secretions, causing aspiration pneumonia, a very common complication. GI tract symptoms include loss of appetite as a result of old age, depression, or medications which induce nausea and vomiting, and they invariably lose weight because of that. And there is increased gastroparesis, and gastroesophageal reflux is very common. Neuropsychiatric symptoms include change in mood, cognition, and behavior. And psychotic symptoms include delusions and hallucinations. And dysarthria and difficulty in phonation may cause inability to communicate and express pain or discomfort. And of course, cardiovascular system, they can have hypertension and no problem. The levodopa is the mainstay. What is levodopa? Levodopa rather, not dopa. What does it do? Have you come across a Parkinson's patient so far?
Levodopa is a dopamine agonist.
Analog. So, will it be able to cross the blood-brain barrier and go to?
No, sir. It will be metabolized by dopa decarboxylase. So we have to give it with carbidopa. So that
Carbidopa, very good. Levodopa can cause nausea, vomiting with associated depression. Old age lead to dehydration and hypovolemia. And adequate fluid management to be done. Number one. Levodopa, acting as a central mechanism, contributes to, can produce hypotension also. Though it is a dopamine agonist, it is can contribute to hypotensive effect. And the most important thing is it's a very short half-life, 1 to 3 hours. So it has to be given in multiple doses per day. So you have to give it even 3 times, 4 times, or 5 times, depending upon the response. So you have to continue the drug on the morning of surgery. The patient is on this drug. Just like you give your thyroid supplementation, this has to be given with sips of water. And which drugs we have to avoid in patients with Parkinson's disease? Which are the drugs contraindicated? Patients have nausea and vomiting.
opioids.
Opioids by themselves will cause nausea and vomiting. But any antiemetics we have to avoid?
Perinoms, metoclopramide.
Metoclopramide and phenothiazines. Okay. So phenothiazine, butyrophenol, and metoclopramide, very, very, very important. These things will precipitate an acute attack of Parkinson's rigidity or tremor very intensely, like an acute crisis. So please avoid phenothiazines like Phenergan or chlorpromazine and butyrophenol group of drugs, which are mainly used as antiemetic, and metoclopramide as a improve the gastric motility. So these 3 group of drugs have to be avoided because they can precipitate or exacerbate the symptoms. Compare regional versus GA in these patients. What are the advantages of regional and or GA in these patients?
Regional is, if it's a peripheral nerve block, that is always safer, sir, because GA, the use of drugs can exacerbate POCD in such patients.
COPD.
Cognitive dysfunction can get worse.
Cognitive dysfunction. Okay. Okay. Yeah, right. So you can compare. RA, it allows communication with the patient. Can always, because it's only, as you rightly said, partly anesthetized. Even a central neuraxial blockade will produce only paralysis of the lower part of the body. The patient will be conscious, awake, and he can communicate. Whereas if you administer GA, patient communication is not possible. And in RA, we don't use muscle relaxants, whereas GA muscle relaxants can mask myopotentials and produce alterations in the muscle power at the end of the surgery. And RA, we don't use any inhalation agents, whereas inhalation agents can sometimes precipitate the features of Parkinson's disease. And RA, less nausea and vomiting, whereas GA, more nausea and vomiting. And RA always produces very good pain relief because of total sensory and motor blockade, whereas we cannot exactly judge the amount of drugs required for pain relief. So comparatively less pain relief. And RA chances of aspiration are less because the patient is conscious, whereas here the chances of aspiration during induction, intubation or extubation are quite high. And tremor and rigidity in unblocked areas may interfere with monitoring, like when you put an ECG lead in the upper part of the body, keeps on jerking, then the ECG tracings may not be normally seen. Whereas under GA, because we completely paralyze all the muscles, interference will not be that much. And which is the preferred drug for sedation in these patients, and what is the reason for that? If at all you want to give a sedation, will you go for benzodiazepine group of drugs like midazolam as you do in all cases, or is there a better drug than that?
Dexmedetomidine, sir.
Dexmedetomidine, to some extent, yes, but more than that, it's an antihistamine. That's the clue I can give you. What is Benadryl?
Diphenhydramine.
Diphenhydramine hydrochloride. Okay, sedation with diphenhydramine is useful, especially for ophthalmic procedures, as it has central anticholinergic activity. Okay, so this will help to control the diabetic, Parkinson's state. Right. And which drugs are considered safe in Parkinson's? Like if you want to give GA, which pre-medication drug, which induction agent, which relaxant, which analgesic, which inhalation agents, like that, which are all the drugs which are safe in Parkinson's disease? So anticholinergic glycopyrrolate is preferable to atropine because it does not cross the blood-brain barrier, which we saw in the last discussion. Ondansetron, a serotonin antagonist, and domperidone are safe for prevention or treatment of nausea and vomiting in these patients. Intravenous induction agents, tipentone decreases dopamine release from striatal synapses. So this may slightly exaggerate the disease process because it is decreasing the dopamine. Ketamine can produce increase in blood pressure. But low dose ketamine, like 0.1 to 0.5 milligram per kg, has been found to be quite safe and useful as a temporary adjunct in this patient. And propofol induced non-purposeful movements can happen, but ideal agent is still considered as propofol for induction of GA in these patients. And opioid-induced skeletal muscle rigidity by fentanyl can add to the existing rigidity. So you have to be very careful by administering this. This is not totally contraindicated, but it has to be administered very, very slowly to avoid this problem of exaggerating the rigidity component. And there are no interaction of non-depolarizing muscular blocking agents. So all ND blockers are safe in these patients. So this is the list of drugs which are used and how they can be, some which are to be totally avoided because mepridine, that is pethidine, has to be avoided because they may be on a drug called seligelin. What is this seligelin? Any idea?
Monoamino oxidase inhibitor.
Yeah, fantastic. It is a monoamino oxidase inhibitor. So there is always a reaction between these two. So what type of reaction will happen if you administer pethidine to a patient who is on MAO inhibitor? What are the types of MAO inhibitors?
MAO1 and MAO2 inhibitors.
MAO-A and MAO-B,
And B.
not 1 and 2. It is MAO-A and MAO-B. Which will be reacting with this? Which MAO?
B, sir.
B. Where is it present? B is present in neuronal tissue and A is present in non-neuronal tissues. Okay. So that is an important reaction that you must know. So if any patient is on seligelin, avoid both pethidine and morphine also. Okay. And so this is a list that you have to keep in mind. So what is the ideal technique? The case scenario that we gave is a patient coming for cataract surgery. So here if a patient has got continuous tremors, is it ideal to go and do a cataract surgery under peribulbar block alone? Or
No, sir.
topical as you do in a normal patient?
No, sir. They'll require general anesthesia.
Any
Due
other
to tremors.
alternative to general anesthesia? Any sedation which I just now gave?
Dexmedetomidine infusion also.
Peribulbar block with IV sedation with diphenhydramine hydrochloride. Just now I told you the best sedation that is possible.
Yes.
Okay, that this can be an ideal combination. Peribulbar block with IV sedation with or go for GA with ET tube and TIVA using other intervention. Along with that, you can supplement with the peribulbar block also. Okay, so these are the things that you have to remember with Parkinson's. Shall we stop?
Any doubts from students? Any questions?
No.
No. Okay. So we'll stop here.
Nowadays, we are not getting so many Parkinson's cases for surgeries.
I have thought it's on the other side. I am
sir.
getting Parkinson's patient every 2 months. One case is I am seeing.
Oh,
Either when you do urology or when you do general surgery like hernia or orthopedic procedures also, I see at least 5 to 6 cases in a year in various degrees of Parkinson's, from mild rigidity to very stiff. Even to make them sit up for spinal, when you want to do a hip surgery in them, it is very, very difficult to position them. That much of rigidity will be there. So it's quite.
Any recent advances will be asked in the exam, sir, about Parkinson's management?
Recent advances, they are for deep brain stimulation, which is the main surgical treatment for very severe degree of tremors to control, especially hand tremors when it is affecting the person's day-to-day life. And when it is a majority of tremor only causing problem and not rigidity, then they respond very well to deep brain stimulation. That surgery is also being done in some of the corporate hospitals by neurosurgeons.
Yes.
So anesthesia for that is also one of the topics that coming up now in the recent advances. So it is just like putting a pacemaker for the heart. You try to keep stimulating the substantia nigra cells to release more dopamine and maintain their normal transmission. It is all the basic concept of that deep brain stimulation. So they will have a pulse generator. They will put the wire leads and implant it very close to the substantia nigra. But it's quite a tedious and a long surgical procedure. It's not so easy like putting a pacemaker.
is mostly done under general anesthesia.
General anesthesia, yes.
Not awake like procedure or a minimally invasive.
Mm.
Yes, sir.
Right. So shall we close now?
Yes, sir. Yes, sir. Thank you,
Okay.
sir. Thank you,
Thank you.
students.
Thank you,
Okay.
sir.
Thank you very much.
Thank you, sir.